in your broadcast. The broadcast is now starting. All attendees are in listen-only mode.
Students at a time, relay live classes, even live surgeries, educate patients in groups. In our specialty, for our fraternity, it can be used advantageously for a focused use for the admins of Facebook forums. There are many Facebook forums. The young students are well versed with them, and live discussions are carried out there. So the admins of Facebook forums can approach 1,000 students at a time, can conduct live discussions with students being able to read the body language of experts, so more interactive and more real. Experts for training directly from premises by the experts. So experts in ultrasound, hysteroscopy, infertility can run live interactive workshops from their premises while carrying on with their routine work and relaying the live atmosphere with the interaction in real time, with participants getting the real feel without the need for traveling. For the AGM, GBM, that is General Body Meeting, Annual General Body Meeting, Managing Committee meetings of FOXY or any associations, they can be webcast live. Now it is so hard to travel to Mumbai for all the MCMs or AGMs or GBMs, Mumbai or any other place in India. For everyone, it's very hard to travel every time, and especially for elections or for policy making decisions. So if they are webcast, you can always take a poll and decide with maximum participation from the members. How do we interact today? I just showed you this. So This is the webinar panel. This is for the sound. This is if I share my webcam, everyone will be able to see me. This is for the, this is the webcam and I'm seeing there. If I, in the coming sessions, you will be seeing panelists in the webcam. So I close this and this is the panel which shares the screen on my laptop. So I can share my presentation for presenting a talk, and then there are other options. So there are options for the audience, for the attendees to raise their hands, to communicate through sounds also, because they can talk and I can listen to them. Then they can type their question here and I can chat with them, answer their questions. The message I want to convey: webinars will take academic learning to greater heights and make meetings more productive with maximum participation by making learning easily available at doorstep and with reduce the costs involved in conferences. Webinars, a good alternative to conferences and seminars. What is a webinar? Everybody knows how a seminar or a presentation looks like and how it is conducted. On one hand is the presenter, and on the other the participants who listen and interact with the presenter like we are sitting here. The only technology that is used here is the projector displaying the PowerPoint slides and maybe a laser pointer. Nobody ever thought that it could get better than this. However, imagine a scenario where you are sitting in your home or office and participating in a seminar thousands of miles away, or maybe you are giving a lecture which is being listened to by hundreds of students around the globe in real time and also answering the questions and doubts. Well, that is what a webinar does. See, here we have 7 attendees. So these 7 people are attending our webinar from various places in India. I can unmute them and talk to them. They can participate in the webinar as you can participate here with the microphone, with the what do you call that? Microphone, right? They can put their questions also here. They can type their questions here. I'll be able to see if they're, see, someone has asked me, didn't started yet, yeah. So I can say started. I'll write down here and post and they'll get the answer that it has started. See, I write it here, post it. And they'll get the answer. So this is how a webinar is conducted and we are conducting it today. It uses modern technologies like the internet, computer and speaker or headphones to cut across time, space and money. This means that neither the speaker nor the participant needs to be physically present face to face. Instead, they are connected by the internet. Thus, you may present, listen or interact with various people at the same time in various regions of the globe. Any questions so far? So we proceed. This is all about evolution of webinars. No one is interested in that. Types of webinars based on the uses and modes of transmission. They can be training webinars. The name indicates what they are for. Educational webinars. The name indicates what they are for. And business webinars. Recorded webinars, like I'm recording this webinar today and I can use it at a later date to relay. Live webinars, like we are conducting it today. Recorded webinars, you record these live webinars and relay it later. Features of webinars: PowerPoint slides and informational audios and videos can be presented and the audience engaged with a markup tool and remote mouse pointers. It can display multimedia files, digital video cameras, full motion webcam. Another feature is the real-time audio communication by the use of headphone speakers. Like today I'm giving a slide presentation. I can play a video here. I can play a sound file here. I can relay anything I want to the public who have logged in. So the presentation activity can be recorded for a later use. The presenter can shift the responsibility on another presenter like I'll be doing today, when someone else will be presenting from Kerala or Gwalior, and the presenter and the audience both can mark items on the slide presentation. People connected to the meeting can text chat for live questions and answers. I showed you just now. It allows conducting polls and surveys. We have some poll questions also ready. Let me try out if people participate. How many are attentive, I don't know, but we can always post a poll. Was I successful in explaining the concept of webinar? So I run this poll, launch. I launched this poll and it is launched on the screen for the people who have logged in, and then they answer. So 40% voted and the answer is 100% people say yes. So that way I conducted a poll. Now the second question which I may ask is, okay, so this is manage polls, close. Then I launch a second question. Are you enjoying participating in a webinar? So I post this and let me see what people say. Has it got disconnected? Something is wrong. Okay. So this is launched question. So 100% say yes, I have been successful. Now the next question, I close this. Then the next question I say, which surgery you enjoyed the most watching yesterday? I don't know how many of them who have logged in where you logged in yesterday, but just let me see if people are there. So tuboplasty, vaginoplasty, sarcocolpopexy, hysteroscopic myomectomy, 100% say, I don't know where did they see. That was not a they are thinking it was a hysteroscopic myomectomy, but it was a TLH. Then the next question, are you looking forward to more webinars? I launched this question and people will answer. Yes, 100% say yes. They will. Then the next question is, vote for which would you like to attend in future for academic sessions? Webinars, CME in person, both depending on my circumstances. So 100% say both depending on my circumstances. How very true. But now again it has changed. So 25% do want to see webinar exclusively. Good. So I have been successful. Then the next is, would you be updating yourself through webinars in future to save valuable time for yourself and your family? I launched this question. Let's see what people say. So 100% say yes. So for the family, they want to save 100% time. So this is how we conduct the polls. Recent webinars, all the gynecologists know that we had webinars by Dr. Pankaj Desai and Dr. Deepika Deka, and it was a wonderful session on 11 to 13 weeks pregnancy. Advantages of webinars, it is the disadvantages of live conferences that prompts us to acknowledge the advantages of webinars. As long as there is internet connection and a computer, you can interact with people anywhere. Enormous expenses are saved against travel and material cost. When a webinar is used, it is the most cost-effective method of conducting meetings. The participants can become a part of the meeting because the features like desktop control and instant polling. The meetings can be conducted and transmitted to and from 2 to more than 1,000 people anywhere in the world. The maximum per persons who can participate here is 1,000 persons. So the meeting, today only 16 have logged in. Maybe this number may increase till 3 p.m. But in coming years, this sure will reach 1,000. The meetings can be conducted in real time and it can be recorded from any point. There is also a co-browsing facility so that two people can check the internet at the same time and in real time. This is especially good for training and research purposes. A webinar has the advantages of being able to set up in a matter of weeks. In the past, a seminar might take months of planning before being carried out, like we did for this one. In the healthcare industry, these presentations also serve the function of keeping medical professionals up to date on the latest innovations in their field. For this CME, we had to prepare many months beforehand. But for webinars, which I regularly hold, it is only a matter of 1 day or 2 days. So the cost, very cheap, up to 100 attendees for $89. This is pounds, I think, per organizer per month, and up to 500, it is $199. It's an eco-friendly mode. A webinar may be easily accessed from the smartphone, tablet. Many of you are using your phone here. You have it open? Okay. I have to close the poll. Right. Close. So many you can open it on your mobile like this. She has been seeing it, hearing my voice, hearing everything from the phone. And similarly, many are seeing it around the world. It is easy to reach your target audience instantly, efficiently with this online communication tool. Those who otherwise may not be able to attend such an event may still be able to access. A webinar may be easily accessed from a smartphone. Here you are sitting in your drawing room, enjoying your coffee and your chips or whatever you like and enjoying the webinar. So that is the advantage. It provides a convenient medium for introverts. Experienced and reputed teachers are available to the wider range of audience spread across the globe. For physically handicapped and old-aged doctors, this is the best mode to keep oneself updated comfortably. And in coming years, doctors will control the industry and not farmers using this mode. Invitations, full service registrations and reminders automatically generated. Easy to set up because you all must be getting, whoever have registered for the CME through for the webinar, you must be getting regular feedbacks on your emails. Easy to set up and host after initial orientation. On-site tech support may not be necessary. Pre-webinar practice sessions may be included in a package deal. Disadvantages of webinars. Believe me, webinars have all the disadvantages required for success, and they sure are a thing for future. Technical difficulties like we encountered today. Audience interaction, quite good I can say, because 100% were responding to my poll questions, and maybe a technical for lacking is here, is there over in this. We are not able to hear their audio, the audio from there. If we had a three-way connection, the people here they don't have, then I would have been able to listen to the people logged in also, and you would also be able to hear to their questions and the answers. Long distance telephone charges may incur if two way voice interactivity is enabled, the instructor cannot gauge the level of understanding among the participants as much as in a live seminar, but once you are talking to your audience, you can always gauge. Now a few poll questions for all that I've already finished. Future of mobiles, 1973, handheld mobile phones, Martin Cooper. 1990, Karina was using this mobile and the common man could not because of the very high rates. And 2013, even a rickshawala and all the your personnel working in your home and your staff, everyone can use it. So the technology brings, with passage of years, becomes easily accessible and also low cost. Future of conferences, this, and finally the webinar in 2006, it was introduced, and in 2016 we are holding it in TMU. In spite of the disadvantages, the advantages are limitless, with net speed increasing in leaps and bounds. The coming years sure promise a bright future for webinars. With scientists working at the teleportation, the day is not far off when a teacher will be beamed into a student's room or vice versa using high-speed net. So I think in 10 years from now, I'll be able to bring faculty from USA by teleportation on this stage and he'll be presenting, or maybe I may teleport Dr. Rehana to USA using technology and she'll attend the conference and come back. So this is teleportation. In coming years, with increasing internet speed, the traffic on roads is sure to reduce with advance in technology, and people adopting these communication modes for travel, business, teaching, learning, and advertisement. So the internet will become our highways, and the billboards will be there, not on the highways, but on the internet, and we sure will progress to an eco-friendly era, reducing noise pollution and pollution as a whole, as also saving time and most precious commodity for tourism. We'll save time for the most precious commodity for ourselves, that is for tourism, mental relaxation, outdoor games, and walks in parks. Conclusion, webinars are sure the future of conferences, being eco-friendly, cheap, and helping an individual to save money and time. They surely bring down the cost of the conferences from crores to thousands for organizers and from thousands to a few rupees for delegates, saving a lot of revenue and time, and are eco-friendly too. Carry home message, webinars have a bright future, so become net savvy. Thank you. With a deep sense of gratitude, I thank you all for sparing your precious time. Any questions?
Thank you, Archana. To enhance our knowledge regarding webinars, it's really very useful for listeners. Thank you very much.
When I first held a webinar, this was the message. Looking forward to seeing you all participants. Looking forward to see you all participate in a web conference if I ever succeed in organizing one. This was 1 year back, and today I can proudly say I have succeeded. Thank you.
Thank you, ma'am, for very clarifying and educative talk. Now I request Dr. Bimita Agarwal and Dr. Anjali Agarwal to come forward and present a memento and certificate to Dr. Anjali Tandon. Sorry, Archana. I request Dr. Bimita Agarwal to present a memento and certificate to Dr. Anjali Agarwal. Thank you, ma'am. Now I request Dr. Anjali Agarwal to present a memento and certificate to Dr. Bimita Agarwal. Now next session is panel discussion and we have to arrange the chair. Please draw the curtains. Now there is some rearrangement. The next session, let us on the next session, which is on double marker, triple marker and quadruple marker. The question is that which one is the best? The chairperson of this session is Dr. Neena Mohan, a leading practitioner in Muradabad, and Dr. Kumkum Mehrotra, a renowned practitioner at Muradabad. And the speaker of this session is Dr. BELA. I request our chairperson to come on the dais and chair the session. आगे डॉक्टर कुमकुम को आगे और डॉक्टर गायत्री से बुलाना ठीक है डॉक्टर कुमकुम डॉक्टर ऋचा I request Dr. Kumkum Mehrotra ma'am and Dr. Richa Gangal to come on the dais and chair the session. कनेक्शन से वो दे जाइए तो ये वेबिनार मिल जाए. ये इसमें पासवर्ड डालना फर्स्ट
Okay, good morning friends. till the time the curtain opens, let me just
Kindly open the curtain.
This is Dr. BELA Bhatt, and I bring greetings first of all from Rainbow Hospital, Mumbai. At the outset, I would like to thank Dr. Archana, who is President of Moradabad Society and a very, very dear friend of mine. And I would also like to congratulate her for taking so much pain for conducting this webinar so that it reaches each and every gynecologist of India. And thanks, ma'am, for making me part of this webinar. I'm sure Anuja sitting here must be very proud of her mother. Right, Anuja? So here we are.
Ma'am, please wait. She'll be introducing you.
Okay, fine. Otherwise, these are all friends only.
Dr. Richa, please introduce Dr. BELA Bhatt. Check your mic, Dr.
Okay. So, Dr. BELA Bhatt, she is MD Obs and Gynae from MSU Baroda Medical College and consultant obstetrician and gynecologist, Rainbow Women's Hospital, Andheri East, Astha Hospital, Andheri West, Mumbai. And she is operator of Fetal Medicine and Foundation of UK. And she is managing committee member of AFG Mumbai, core committee member of Youth Mela Ethoxy Project. Born PCPNBT case, Bombay, High Court by fighting is in person, special interest in fetal medicine, gynae, ultrasonography and infertility. She is faculty at many states and national level conferences, and she is master of ceremony of several states and national conferences. So I will ask Dr. BELA. Thanks, Chairperson, for kind introduction. And the topic given to me today is the best in the quest, double, triple or quad marker. I'm sure you all must be familiar with these terminologies, especially the triple marker, because we have been using it since years. Now that double and quadruple markers have come, we better know which one is the best out of all three, whether it's double marker, triple or quad test. The first question that comes into our mind is there a need for these tests at all? We all know that these tests are basically to find out whether there is chromosomal anomalies in the fetus, whether it's commonest chromosome, trisomy 21, 18, 13, right? But then whether it is necessary at all to find out chromosomal anomalies. Previously we used to do only congenital anomaly scans at 18 weeks, that's fine, structural anomalies are ruled out. So why so much hue and cry about chromosomal anomalies? Well, the answer is yes, because we know these days because of late marriages, late pregnancy, career-oriented women, we get so many patients at advanced maternal age in pregnancy, beyond 35 years of age. In 1970s, there used to be only 5% pregnant women who used to fall in this category of more than 35 years of age. Whereas now we see almost 20% of females who fall, pregnant females, who fall in this category of more than 35 years. And so, in 1970s, there used to be only 30% fetuses with trisomy 21 who used to fall in this category of more than 35 years of age. Whereas, now we have almost 50% of fetuses that comprise this age group. So naturally the burden of problem is increased because of increasing maternal age. So all hue and cry about chromosomal anomalies and detection is increasing because of this particular reason. We want to find out, and not only we want to find out, we want to find it out at the early age in pregnancy. So basically all these double marker, triple marker, quad marker are part and parcel of biochemical markers, which are again a part of prenatal diagnostic techniques. So these either sonography, that is Nuchal scan, which I'll be talking about in brief, or biochemical markers, which are screening tests along with diagnostic test, that is chorion villus biopsy or amniocentesis, lead us to the diagnosis whether the baby is having chromosomal anomaly or not. Now, why are these tests known as screening tests? As I have mentioned, this ultrasonography, that is Nuchal scan, or biochemical markers are part of screening test. Why are they called screening test? Because either of it is only for screening and not for diagnosis. This is something which is very, very important for all of us to understand. These are just screening tests. And in conjunction with the age-related risk of patient, it is useful to help determine the need for more invasive tests. So basically this tests help us to segregate low-risk population from high-risk population, and then this high-risk population is suggested invasive test. I repeat, we just suggest invasive test and we don't offer invasive test to patients. When we see that the patient is in high-risk group, we offer them, we just suggest them that now if you want to go for a definitive diagnosis, then you may have to go for invasive test, either chorion villus biopsy or amniocentesis based on the weeks of gestation, and that will give you definitive diagnosis. So that's the difference between screening test and diagnostic test. So it does not have the same predictive power of amniocentesis or chorion villus sampling. So it is not a definitive test. The patient has to be well informed before carrying out any form of the screening test, be it a sonography, nuchal scan, or double marker, triple marker, quadruple marker. And if some abnormality is detected, then it helps us decide whether to continue the pregnancy or terminate. Again, this is patient's take. The baby is having some chromosomal anomaly or some structural anomaly. We just have to explain about the possible prognosis, and it is ultimately patient who decides. Sometimes even a patient with trisomy 21 may decide to carry the pregnancy. So it is entirely patient's decision. If continue, then managing the remaining weeks of pregnancy, determining the outcome of pregnancy, planning for possible complications during delivery, planning for problems that may occur in newborn or infant, and finding conditions that may affect future pregnancies. That is prognostication. Now let us first understand as to what is double marker. This is a newer test. As the name suggests, it involves measurement of two hormones, that is free beta HCG and pregnancy associated plasma protein, or we call it as PAPE. So beta HCG and PAPE, these two form double marker test, which is to be carried out at 11 to 13 weeks, though it is better for PAPE to be conducted at 9 to 10 weeks of pregnancy, but usually the time limit is 11 to 13 weeks. For second trimester markers, they have to be done between 15 and 17 weeks, which include the triple marker, which is age old, and I'm sure everyone sitting here must be knowing about it. The HCG, alpha fetoprotein, and unconjugated estrone. And the quad marker also includes inhibin A, which is a newer test. Now you must feel that this is a costlier test and why to go for this. Well, I'll come to that as to which one is better out of these two. The only important thing here I want you all to understand is that these tests have to be carried out, if at all they are carried out, between 15 and 17 weeks. Why? Because suppose after this test the patient falls in a high risk category. What is the next suggestion to the patient? Invasive test to confirm whether the baby is having chromosomal anomaly or not. And that test is amniocentesis, which gives a routine karyotype, takes 21 days. So if you do this test as 15 to 16 weeks, you will get your result by 19 weeks. And we have, if at all patient wants to terminate, the legal limit is 20 weeks. So we want a result before 20 weeks. So please don't do it at 18 and 19 weeks. There's no point in doing it 18 and 19 weeks. Because even if the baby is chromosomally anomalous, we'll come to know at 21, 22, 23 weeks. And the patient can hardly do anything legally. So ideally you should do it between 15 to 17 weeks of pregnancy. Interpretation of all these biochemical markers are based on age, ethnicity, gestation weight, singleton or multiple, diabetes mellitus, smoking, IVF, and the risk is calculated and adjusted for all these factors. Now what does a positive test mean? There can be different interpretation for this. There can be nationally decided cutoff for this. For trisomy, it is 1 in 250. For trisomy 21, for trisomy 18, it is 1 in 100. The test can also be said positive. The risk of having chromosomal anomalies more than age-related risk for that particular patient. But to me, what is most important is the fourth one, and that is patient's own attitude towards risk. See, if you carry out any of the tests, you must have seen in the result, they give a number. The chance of trisomy 21 in this particular fetus is 1 in 1200 or 1 in 750 or 1 in 100, whatever. Now suppose the report is 1 in 750, right? Now you put it in intermediate risk or low risk, but there can be two kind of patients. One patient may think that 1 in 750 is the risk. That means there is a chance that 1 in the 749 will be normal. Only one is affected. So I don't want to go for invasive test. There's a chance of abortion in invasive test. 1%, 2%, whatever. So it's fine with me. 1 in 750 risk is fine with me. And I don't want invasive test. Whereas the other patient may feel that the risk is 1 in 750 and what if that one is my baby? I want to be 100% sure. Doctor, carry out the needle test and rule out, I want the 100% result. I want to know the karyotype. And so it's basically patient who decides. Everywhere in this, all these states, ultimately it is the patient who's going to make decision. You are just supposed to explain to the patient as to what is the risk. You are supposed to give the number to the patient. It is patient's take whether to go for invasive test or not and confirm. Now suppose the report comes in high risk as per our criteria. Now what do you have to improve? Suppose the patient doesn't want invasive test. Patient says that I want to improve the performance of screening test. What else do we have? Suppose you have done a double marker at 11 to 13 weeks. You can combine it with a nuchal scan. I'll come to it because it is definitely a better combination. Or if the patient doesn't want that, in the second trimester, we can go for either triple or quad. And suppose the patient has come only late and you've done triple or quad, in that it has fallen to high risk. You can go for a little anomaly scan, which you usually do, but there is genetic sonogram now, in which there are 9 soft markers of trisomy, which are also looked for to find out whether the baby is having chromosomal anomaly or not. As far as interpretation of all these double marker, triple marker and quad marker is concerned, the double marker, as I've said, beta-HCG and Pepe are taken into account. In trisomy 21, the beta-HCG is high, that is more than 2 MOM, and Pepe is low, that is less than 0.5 MOM. Whereas in trisomy 18 and 13, you find both of them are low. If you do a quad test, you will find that beta-HCG and inhibin A are high, whereas rest all are low. And in case of trisomy 13, AFP is high, rest are low or normal. Now, a positive test in case of triple and quad test means having a high risk of chromosomal anomalies or neural tube defects in which AFP may be high, gastroschisis or omphalocele, or multiple gestation, in which again these hormones are going to be high. And in addition to Down syndrome, it also gives information of some other conditions like Turner syndrome, triploidy, and some other conditions. Now you must be thinking that almost half the talk is over, but we have still not come to the conclusion as to which is the best, whether it is double, triple or quad. Well, suspense is best disclosed at the end, and so I'm still going to keep you on hold because before we come to this conclusion, we need to know about 2 more things, which is age-related risk of trisomies and nuchal scan. What is age-related risk? We all know that with increasing maternal age, the chances of chromosomal anomaly increases. At the age of 20, it is 1 in 1527. This is term risk of trisomy 21. At the age of 25, it is 1 in 1352. And at the age of 35, it is 1 in 356, and so on and so forth. So with increasing age, the chances of all these trisomies increase. The second important thing we need to know about is nuchal scan. You must all of you must have heard about it, and we are going to discuss it in detail in the next panel discussion. It is to be conducted between 11 to 13 weeks, 5 days. Not going into detail of it. We have to measure the nuchal translucency and nasal bone, and there are 2 more markers also, tricuspid flow and ductus venosus. And based on that, again, you get a risk. How you get a risk in biochemical test? One in 1200, one in 1500, one in 750. Similarly, after Nuchal test, when you put it in a software, all these measurements, you get a risk. Now, this is the most important slide, which decides which test is better than which, depending upon the sensitivity and specificity of the test. If you take just maternal age into account, the sensitivity is just 30%. You include double marker along with maternal age, the sensitivity improves to 60% with 5% false positive rate. You just take maternal age and nuchal translucency, 80% sensitivity with 5% false positive rate. Maternal age, double marker, that is beta-HCG and PAPE, and nuchal translucency, the sensitivity increases to 90% with 5% false positive rate. Double marker, maternal age, nuchal translucency, and nasal bone. Again, one more marker of trisomy 21. The sensitivity increases to 94% with just 3% false positive rate. In this group, we also include the ductus venosus and tricuspid flow. So overall, you can say that double marker with nuchal scan, the sensitivity is 90 to 94%. You can yourself see that the highest sensitivity is with this test. Maternal age and only triple marker. Now, please look at this. You have been doing this since years. Look at the sensitivity of this test. Just 65 to 70% sensitivity. And look at the sensitivity of double marker plus nuchal scan. 90 to 94%. You want to give better result to the patient. When the test comes positive, you should be able to say with surety that there are all chances that baby is having this and therefore you should go for invasive test. You can at least suggest with surety if the sensitivity of the test is high. So with triple marker, the sensitivity is just 65 to 70%. It's almost the time that it becomes obsolete. Triple marker is not to be done. If at all you want to do, go for quad marker, which is 81% sensitive. What test? Little expensive, but the patient need to understand. They need to realize that they have to go for a more sensitive test. An integrated test in which we take into account first trimester PAPE and second trimester all triple marker markers. So total 4-5 markers. Sensitivity is 91%, but again it is little late in the second trimester. So out of all, I don't need to tell you which is the best test now. I think you know for sure that which is the best test, and that is double marker with nuchal scan, which is known as a combined test. So it is a combined test which gives you the best sensitivity with least false positive rate, and so it's a clear winner. Why? There are reasons also for the same. It is a non-invasive test. Sensitivity is highest 90 to 94%. Result is provided at earlier gestation. It is 11 to 13 weeks, first trimester. So there is enough time for decision making for patient whether to go for a better screening test or whether to go for invasive test. Some structural anomalies can also be picked up as early as 11 to 13 weeks. There are many anomalies which can be picked up. So if at all some abnormality is picked up, early in say first trimester termination is possible as compared to second trimester termination. In case of doubt, if only one of the two is high risk, then patient may go for second trimester markers and anomaly scan or genetic sonogram for improving the screening performance. Suppose you say that we want to do double marker and nuchal scan and everything, but the patient only comes late, 3.5, 4 months, 4.5 months, what to do? Then there are two options, but I think you know which one to go for now, right? Not triple marker at least, right? Because sensitivity is just 65 to 70%. If at all you have to opt between these two, please go for quad test and not triple marker. Oscar test, this indeed needs Oscar as far as fetal medicine is concerned. This is one-stop clinic for assessment of risk, though not every lady is ready for this. But this is the latest prenatal screening program for Down syndrome introduced from Fetal Medicine Foundation of UK. It is conducted between 11 to 13 weeks of gestation, where double marker and nuchal scan are done, and those who fall in high risk are suggested Korean villus biopsy. Those who agree, they conduct it on the same day, and within 24 hours they get the result. So within 24 hours the patient comes to know whether the baby is having chromosomal anomaly or not, and the detection rate is as high as 90%, which is now routinely performed in UK. Still it will take some time here because the patient acceptance is not so high. Plus we don't get result on the same day. Even if we go for fish, we get result after 5 to 7 days. As far as the future of this is concerned, use of fetal cell DNA in the maternal circulation for prenatal diagnosis, and which may negate the need for Korean villus biopsy and amniocentesis. But again here the PCP&D issue comes, especially in Maharashtra we are not allowed to do NIPT because of the PCP&D issue. And the second and very important thing is cost effectiveness. This costs almost 30,000 to 35,000. So again, in India it is not all that feasible. So what we have at present, and out of all, I suppose you know which is the best, the double marker with a Nuchal scan, and if patient falls in high risk along with invasive tests, you can reach to the diagnosis whether the baby is having chromosomal anomaly or not. Thanks for patient hearing. Thank you.
Thank you, ma'am, for your very informative talk. I think Dr. Kunku wants to. Ma'am, please highlight some medical legal issues if we don't get it done, or sometimes when.
See, basically we are supposed to offer this to, see, it's not that we have to offer it to high risk patients only. No. Screening is meant for entire population. So each and every patient coming to you in the first trimester, you should sensitize right from the 5 weeks, 7 weeks she comes. You should tell that these are the things. In fact, those who are educated, little educated, even if you tell them at 7, 8 weeks, please go and Google what is Nuchal scan and what is double marker. They'll go, they'll read, and they come back, yes ma'am, we want to get this done. Right? And if not educated, you have to sensitize them. See, these are the things that we have to offer to you. Whether to go for it or not is into your hand. Whether it is financially possible for you or not is in your hand. You can put it on paper. Because these are the things we had recently last to last year, we had one case in Mumbai itself where the baby was down, and she claimed on doctor that I was not offered any screening test. So yes, for us it is important that we have to offer to patients that these are the tests available.
There should be evidence on paper.
Yeah, exactly. On paper, at least you should mention advise Nuchal scan double marker. Whether then they get it or done or not is there.
One point that I would wish to add and required can be done up to 26 days.
It is just because of legal limit. Yeah. Yeah.
Because after one week, you don't do it has to be a diagnostic, not another screening.
Diagnostic only. It is just to improve the screening power. Otherwise, diagnostic is best.
Combined test is 90%, but then the sensitization should be for the 20% of those who are doing it, and sometimes 20% can be made.
That's what. Whenever we do any screening test, we tell the patient these are not diagnostic tests, these are just screening tests. And if at all you want a 100% diagnosis, you have to go for an invasive test. That is something which has to be stressed upon. Yeah, always counseling is the most important part of it.
Thank you, ma'am. Thank you, BELA.
Thank you, ma'am, for your illustrative talk. Now I request Dr. Kumkum Mehrotra and Dr. Richa Gangal to present a certificate and memento to Dr. BELA.
I can hear it, it's okay.
Please switch off the light. Switch on the light.
session. This should be okay.
I request Dr. Kumkum Mehrotra to present a memento and certificate to Dr. Richa Gangal. I request Dr. Richa Gangal to present a memento and certificate to Dr. Kumkum Mehrotra. Thank you, ma'am, for your kind support and coming. Now, next session is panel discussion on 11th and 13th week scan. I request our respected chairperson, Dr. Rehana Nazam, and Dr. Gayatri Singh, a renowned practitioner at Muradabad, to come on the dais and chair the session.
No.
Dr. Shilpa, no, sir. Okay, phone call. 11 to 13 By the time we are waiting for Dr. Gordon है तो उनकी करा दो तो
I welcome and introduce Dr. Shrestha Agrawal.
Ma'am, please wait for a moment.
Yes.
Nothing may be coming. Nothing is coming.
I can do it better this way. You have a problem?
No.
Why are you talking? नहीं है ना? नहीं है. डॉक्टर शीतल को फोन करेंगे. उसका वेट करेंगे. बता दो कि वो.
Dr. Shrestha Agarwal is our moderator for this session. We will be having a panel discussion on 11 to 13 weeks scan. And we are waiting for one panelist, Dr. Shilpan Gondalia. He is in OT right now. He will be coming and joining us. And till then, I request Dr. BELA to join the panel discussion. Dr. Bharti Ghetri from Kashipur to join the discussion. And Dr. Rajul Rastogi of TMU. Dr. Asta, you will also like to join the panel discussion? Achha, you will like to join the PPHR. So, Dr. Gayatri Singh, please introduce our moderator, Dr. Shrestha Agarwal.
I welcome and introduce Dr. Shrestha Agrawal. She is a gynecologist by birth and fetal medicine specialist by faith. She did MBBS in 2000, PGO in 2002 and MD in 2003 from SMS NHL Municipal Medical College, Ahmedabad. One of the youngest to complete MD at the age of 25 years. Practiced obs and gynae for 10 years and developed a keen interest in fetal medicine. I cleared online exams of fetal medicine. She cleared online exams of fetal medicine Foundation UK and she was one of the few hundreds of the license by them. She did an observationship in Bangalore Fetal Medicine Center. She started full-fledged fetal medicine practice in 2015 and the first fetal medicine specialist of her area to bring the best possible care for every expectant mother and optimum outcome of every fetus. She already had to my credit many unusual cases and diagnoses, bringing every anomaly to its logical conclusion for prognostication of current and future pregnancies is her passion. Thank you, Dr. Sharma.
A very good morning, everyone, and thank you so much, ma'am, for such kind words.
Sorry for interruption. We'll be checking the availability of Dr. Asha Risinghani from USA. If she's available on the webinar, she'll also join the panel discussion.
Yeah, so our task has been made, I should say, easy or maybe difficult by Dr. BELA Bhatt. I presume everyone present here is an obstetrician. Is that so? How many of you offer first trimester screening or NT scan or a dual marker as a routine to your patients? Okay. And to high-risk patients? Exactly. Exactly. Thank you so much. So that makes my job a little easier. Yes. Fetal medicine as such is a subspecialty of obstetrics only. Just as ma'am said, I am an obstetrician by birth, but a fetal medicine specialist by fate. So this brings us to this topic, 11 to 13 week 6 days scan, where we stand today. Is it actually a myth or we are showing stars that is not possible, but it is just a marketing gimmick? Well, let's see how we conclude with our esteemed panelists. I'll just give a brief introduction to the topic that has already been given to a large extent. In the 1980s, amniocentesis was the only procedure available for genetic testing, and as a policy, it was offered to every pregnant woman above the age of 35 years. But as Dr. BELA Bhatt said, at that point in time, and even till now, most of our reproductive population is constituted by much younger women. And hence, most of the aneuploidies, almost 90% of them are missed if we were to offer the invasive testing only to the pregnant women above the age of 35 years. Hence, the need for a screening test for this population was felt. Gradually, this resulted in evolving the concept of nuchal translucency and the first trimester screening. So why a first trimester scan? We've already been doing our anomaly scans at 18 to 20 weeks. The reason has been we have equipment available much more than what we could at earlier times. Now we understand the human embryology in a much better manner, and in an unfortunate event of a defect, it avoids the determination. And at the same time, in high-risk pregnancies, it is highly reassuring for the woman to know that yes, her baby is going to be fine. So with time, the ultrasound has evolved into two kinds of tools, as a screening tool for chromosomal defects and preeclampsia, and as a diagnostic tool for dating if it has not already been done, to establish the chorionicity and amnionicity in multifetal pregnancies, and also for anatomic evaluation of the fetus. So this brings to my first question. Dr. Bharti, how do you would use the screening modalities to get the optimum results?
As in the previous lecture, Dr. Veera has already explained that how in the first trimester, we are first going to the universal screening. Still, maternal age holds importance. And when we only use maternal age as a screening test, then the chances of detection is 30%. And we all know that each and every female, pregnant female, can have a Down syndrome baby. So, we follow a sequential methodology. We take this thing as a background risk, also called as a infrared risk. And all the different screening methods, including the biochemical markers, as well as the ultrasonological markers that we measure in first trimester, like the biochemical markers that happen and we combine, along with the translucency. When we take them to they act as likelihood ratio. And by adding each and every ratio, a single ratio to the A parameter, we have a new risk with us. And the moment we keep on adding a new screening test, our detection rate increases. So the first thing is to follow a sequential stepwise methodology. And as ma'am had already told you, that new things have come up, like the detection of nasal bone in trisomy 21 detection, and the digestion measurement, as well as the cytosolic verification. They further help us to improve our detection rate and thereby optimizing the result. Another thing which is very important is the ability of the ultrasonography or the operator. So this holds the key because to measure the nuclear translucency in the vacuum, as well as the measurement for ductal stenosis and looking for the mutual bond, this is very important. Thank you.
The audience is always welcome. You can raise your hand and ask a question at any moment if you like. So this is the slide for the sure.
Optimum screening for any patient will depend on what sub-gestation patient presents to us.
Exactly.
Suppose the patient presents to us in first trimester, for screening purpose definitely would be combined test.
This is what we are discussing today. It is only 11 to 13 weeks. Definitely. So this is basically a chart to represent how the risk for the trisomies increases with the maternal age. This is the background risk, and we keep adding the markers to improve our, get the final patient specific risk. So this brings me to the next question. Dr. Shilpan has just come from the OT and straight away bombarded with the question, why should there be a limit of 11 weeks or 13 weeks? Why not earlier or why not later? Sure. In the min.
Okay.
For all screening purposes, we basically take the CRL as 45 millimeters to 84 millimeters. 11 to 13 weeks is basically just a representative figure. It is basically the CRL that is taking into consideration.
Before 14 weeks, if you want to if you require termination, then it would be first trimester termination. That would be easier. And earlier than 11, if some invasive procedure is required, then it would not be possible. If we require CVS or coronal sampling, then before 11 weeks it is riskier. Means it increases the risk of limb reduction defects like that. So that's the main reason we have kept it 11 to 14 weeks.
So is that clear with everyone? Yeah. Megacystis, physiological herniation of the bowel, all this acrania, all these defects can be detected only after that if the gestational age is more than 11 weeks.
And beyond 14 weeks, technically also
yes. Yeah. Even in chromosomally abnormal babies, the anti-met absolutely resolve. So the next question, what is nuchal translucency and how to measure it? Dr. BELA.
Basically, it is the ultrasonic translucency that we see behind the neck of fetus because of fluid collection. And there are specific criteria how to measure it. Number one, the zooming should be such that only the head and upper thorax occupies the entire screen. There has to be a mid-sagittal section in which the tip of nose, a square palate, and a translucent diameter colon at the center, and nuchal membrane at the back. The zooming has to be such that with every movement of our cursor, we see only 0.1 millimeter movement increasing the measurement. And the cursor should be set in such a way so that the horizontal bar fuses with the inner lining of that defining space. So that we get the exact measurement. The highest measurement has to be taken. It has to be taken 2 to 4 times, and the highest measurement It's all criteria should be taken into account. And we have to see to it that we are not looking at amniotic membrane, which can be significant movement going away from the initial membrane.
So, the nasal tip, the nasal bone, the square-shaped palate, the diencephalon, and the nuchal membrane. I hope the things are clear, and I'm not confusing you any further.
Pardon, ma'am, what is the prognostic value of only increased nuchal transmission?
We'll come to that. So this is from the FMF website that the nuchal translucency gradually increases with gestational age, and a 2 millimeter crown rump length is the 95th percentile at 45 millimeter of gestational age, which comes to about 3.2 millimeters at 85 millimeters of gestational age. So 3.2 millimeters may be abnormal at 11 weeks, but 3.2 millimeters is absolutely normal at 85 millimeter of gestational age. So this brings us to our next question. How would we manage the fetuses with increased nuchal translucency? Official thing.
You should go for CVS to rule out any chromosomal anomaly. But if at all report of karyotyping comes back to normal, we should advise the patient regarding target scan at 20 weeks, and also we should rule out any cardiac anomaly at 20 to 22 weeks of gestational age. And if there is increased nuchal translucency, apart from chromosomal anomalies, there are chances that their fetus may be having many other anatomical abnormalities.
Just to add, so does that mean at increased nuchal translucency means we should abort the patient, abort the baby? No.
Also,
No.
for the nuchal translucency has been taken into account, we have to look for other key subcompartments that the nasal bone, extracellular and glycosyl.
And double marker should also be included.
Everything. That this is all step one. So the clinical implications, we will review the patient at 14 to 16 weeks to check if the nuchal translucency thickness increase has resolved or not, or if it has at all evolved into a nuchal edema or a cystic hygroma. If it persists at 14 to 16 weeks, there is a possibility that there might be congenital infections or other genetic syndromes which are beyond trisomies and a karyotype. And if it persists at 20 weeks also, then we do need to tell them that there is a 10% risk of evolution to hydrops and perinatal death or a live birth with a genetic syndrome like Noninvasive. But at the same time, the point that I wish to convey from this podium is an increased nuchal translucency or an increased risk in first trimester does not mean that we abort. So many of the babies, even if the nuchal translucency is something like 5 millimeters or 5.5 millimeters, may be absolutely normal as well. So we need to get our risks calculated and give the exact figure to the womb. So this brings me to the next question. What are the other markers for chromosomal defects at this gestational age? I mean to say maternal age we've already taken into account, gestational age we've already taken into account, and nuchal translucency also we've already taken into account. Dr. Bharti.
Now, as we have already discussed earlier, the other markers that we include just after the nuchal translucency is the measurement of ductus venosus, then looking for the nasal bone. If a nasal bone is absent or hypoplastic, then there is 60 to 70% chance of the baby being trisomy 21 and 55% chance of being trisomy 18. Now then we add to the tricuspid revegetation. Any presence of tricuspid revegetation again is a marker for trisomies. Then there are other markers in the form of structural defects that are present and they point towards different trisomies, like the presence of shock maxilla, which is an indicator of trisomy 21. Then we can see when we measure CRL, if it is less, it is sometimes a marker of, it points towards growth restriction, which is again seen in trisomy 18 and 13. Then the presence of tyrosine is Xamphilos, that is also seen with trisomy 18. Then trisomy 18 also shows presence of bradycardia, and then in trisomy 13 we sometimes see holoprosencephaly, we see tachycardia, and also the presence of Xamphilos in these cases. So they are sometimes added markers that we should look for in such cases.
Perfect. So, but at the same time, although I have tabulated them, but these can be overlapping. Megacystis can be there in trisomy 18, and similarly a single umbilical artery can be there in trisomy 13. So unless we have our karyotype report or a FISH report, we cannot be sure. We can't label that this is trisomy 18 or this is trisomy 21 or trisomy 13. So just as we keep adding our markers, Dr. BELA has already elucidated in a very fine manner that the detection rate of trisomy 21, as we take it as a benchmark, is best when we combine the maternal age, the nuchal translucency, the nasal bone, and the dual markers at 11 to 14 weeks. We won't be going into the biochemistry because since it is already being taken up. So this is the next question. We don't have Dr. Asha Singhani with us. So I'll post this to Dr. BELA.
I'm here.
And what is the sensitivity and specificity of this screening at this gestation age?
And we have to start right from the history, the demographic factors, the BMI, past history of pregnancy, mother, smoking, and all these demographic factors, along with the mean arterial pressure and pattern. These are the three things that will help us predict preeclampsia at 11 to 13 weeks nuchal strain. And the sensitivity of this, when all these factors are included, it is around 88%. It is 10% false positive rate. So we can predict it, especially the early PIH is more sensitive for early PIH rather than late.
Basically, what worries us is the early PIH. Late PIH is still better manageable. There are biochemical markers also, a PAPE as well as the placental growth factor. But as of now, I don't think there are, at least placental growth factor is not being routinely offered. So we should stick to the mean arterial pressure, the history, and the uterine artery PI. Especially coming to uterine artery PI, a normal uterine artery PI at 11 to 13 weeks has a high negative predictive value, meaning by that if the uterine artery PI is normal or within the normal range at 11 to 13 weeks, we can be relatively comfortable that this patient most probably would not develop PIH or IUGR. So again to Dr. BELA, how can we diagnose chorionicity and amnionicity in multifetal pregnancy?
The first and most important thing is it can be diagnosed, chorionicity can be diagnosed as early as 10 weeks of pregnancy. So in first trimester itself, we can diagnose. And there is a lambda sign and T sign for the same. Lambda sign is the placental, triangular placental extension which can be seen at the junction of mammary and placenta, and that is diagnostic sign of dichorionic pregnancy, which is definitely seen right from 10 to 14 weeks of pregnancy. May not be able to see after that, but that doesn't negate dichorionic pregnancy after that. The 10 to 14 weeks is the right time we should diagnose the chorionicity. And in case of monochorionic pregnancy, this is not present, so that you get inverted inside at the junction of mammary and placenta. So this is how you diagnose chorionicity in first trimester. So any report of twins has to go with chorionicity. You can't just write a twin life in gestation. You have to mention whether it is dichorionic or monochorionic, because the prognostication of both is very, very different. You have to counsel the patient that these are likely complications because it is monochorionic, whereas it is better if it is dichorionic.
I hope it is clear to everyone. So the next question, why are we so much worried about monochorionic pregnancies? Because of all the complications like TTTS, that is twin-to-twin transfusion syndrome. Dr. Bharti, in monochorionic twins, can we predict twin-to-twin transfusion at 11 to 13 weeks scan?
Yes and no. It is seen that in monochronic twins, the presence of twin-to-twin transfusion only if it is severe in the early stage. Then only there are certain markers that are also they are just in signs. So there are very small samples that have been taken. But I will just mention one is that when we are measuring the NT, if there is a discrepancy between the nuclear consistency of both the fetuses, then this sometimes predicts towards that the baby will develop twin, the baby will develop into twin transfusion, and the chances of prediction is that it can predict around 30%. Then the other finding that is still undergoing studies is the ductus venosus. Now, ductus venosus, when we measure both the ductus venosus, the baby, which is the affected baby, that is the hypovolemic baby of both the amongst the monochronic twins, sometimes shows reverse or absent absent flow.
That indirectly would be a sign of failure only, actually.
Yeah, again. So this is another predictor, because what is happening in TTTS is that one baby is hypovolemic and other is hypovolemic. So this is again.
So as of now, whenever we are measuring the NT, if there is a discordance in NT measurement of one fetus and the other fetus by more than 20%, almost 30% of these babies will develop TTTS. On the contrary, a lesser discordance would almost ensure a normal monochorionic pregnancy. The risk of TTTS is less than 10% if the NTs of both the fetuses are almost matching. So the most important, actually, aneuploidies was the primary reason that the first trimester screening was introduced, but I can assure you that even anatomical defect detection is really highly sensitive at this gestation. So Dr. Shilpin, how realistic is anatomic defect detection at this gestational age?
Yes, it's true. We detect almost more than 90% of the anatomical defects in young scan.
These are just the normal anatomy I've given. That this is all 11 to 13 week scan pictures that I've given here.
Even major cardiac anomalies also you can detect. You can confirm at 18 to 20 weeks, but at least you can detect very well major cardiac anomalies. So nowadays we go for.
It's saying hi. The hand saying hi, everyone.
11 to 14 weeks scan for anatomical abnormality.
So would you like to elaborate the kind categories of defects at this gestation? There are some anomalies which are always detectable at 11 to 13 weeks. Some can be potentially detected and some are undetectable. I've just given a brief list of what can be seen and what can be detected. Acrania, omphallocele, omegacystus, holoprosencephaly. Just as Dr. Shilpin was saying, cardiac defect, this is a left hypoplastic heart. You can see this, the left side is, this part is relatively smaller than compared to the right part of the heart. A TOF and an AVST. So if we have, with your permission, 5 minutes to, alright, so we'll just skip this. Just one case I'll just. Though this is a second trimester case, but just an interesting thing. Anything wrong with that head or vein? Anyone? Panelists will get it at the last. Anybody from the audience? Sure, it gets passed to the panelists, experts.
Strawberry head.
Yes, this is classic strawberry head. And what were the other findings in this fetus? A subaortic ventricular septal defect, single umbilical artery, and clenched fist with pointing index finger. This was a trisomy 18 confirmed on amniocentesis. So this is what Dr. BELA was talking about, is the value of genetic sonogram. This fetus was picked up on ultrasound having trisomy 18, a low risk 23 years primary who had come at 21 weeks for an anomaly, unfortunately. Thank you so much.
Thank you, Dr. Shrestha, for moderating the session so well. I would like to thank all the panelists, and I would request Dr. Rehana Najam to please present a memento and certificate of participation to Dr. Bharti. Please present memento and certificate of participation to Dr. Gayatri Singh, a very senior gynecologist of Moradabad.
So we've got permission to go ahead with the quiz questions.
Certificate to Dr. Shilpan and Dr. BELA. Dr. BELA and Dr. Rajul Rastogi from TMU. Dr. Gayatri Singh and Dr. Rehana Najam, please jointly give the memento to Dr. Shrestha. She has moderated the session so well. She'll be continuing with the quiz, I suppose. Any questions from the audiences? You can continue with your quiz.
I'll come. Okay. Can you please switch off the slide? So, just to get your head scratching, I'll keep my well-earned memento on the side. Any clues about this? Anybody? Except the panelists, of course. Yes, this is bilateral CTEV. Whenever you see the leg and the foot in the same section, this is CTEV. This is again a marker. This was supposed to be a video if this runs. Yes. Anybody? Yes, there are two things actually. This is twins with one twin having a sacrococcygeal teratoma. Should I run it again for? Okay. This thing, you can see it at the end. The small tumorous thing, this is the sacrococcygeal tumor, and the other baby is having a nice time seeing its sibling in trouble. Huh? So this is a self-explaining slide actually. Anyone who's doing ultrasounds? Anybody? These are lying down adrenals and there are no renal arteries. So this is bilateral renal agenesis. That I won't show. That is my secret. Huh? That is artistry. So this is again around 13 weeks only. I already covered it earlier. Yes, this is hypoplastic left heart, which was detected at around 13 weeks. You can see that the left side of the heart is smaller as compared to the right side. The LV is much smaller than the RV. Very easy. Perfect. So this is the point that I actually, sorry? Yeah, double bubble sign suggestive of duodenal atresia. The point I wanted to stress was this is a marker of Downs. So all these babies need to be tested for Downs. Second thing, by the time we see double bubble, the baby is usually about 24 weeks. So this is a late sign. Any clues about one of the commonest anomalies? The incidence is almost 1 in 250 at 12 or 13 weeks. Highly lethal. This is cystic hygroma. You can see the sacs, the two sacs bulging on the either side of the neck. This is cystic hygroma. This is a little, yeah, this is the spine. This is the head, the neck, and the spine because of the abnormal posture. And these are the two dilated jugular sacs on the sides. Very common. Again, highly lethal, and almost 75% of these are associated with aneuploidies. That's all. Thank you so much. Special thanks to TMU and Dr. Archana Tandon for giving us this opportunity. So, okay, so brings back to the favorite head. See, this, this would usually go past as a normal. But if you see, this is more of a rounded kind of a head. When we take the cephalic index, the cephalic index was something like 87.7, which is normal. Up till 86 is the cutoff. And the shape itself, see, ultrasound is basically about pattern recognition. The more you get accustomed to how a normal head looks, this is what struck me. There's something wrong. Immediately at that point in time, I was not smart enough to say that yes, this is strawberry head. But once I have the diagnosis, I have the confidence to stand in front of you and say that yes, this is strawberry head. They don't come labeled, yes, yeah, hi there, I'm a strawberry head. No, it doesn't come like that. It is just that you come to feel that there's something normal, something not normal about this. And then you start looking. And when you start looking, you find other markers, the detection increases. Any questions from anyone about first semester screening? Either everyone is too confused or everyone is too clear. I think Dr. Parul is on his way.
Thank you, Dr. Shrestha. You all can have a tea break till then. We are waiting for Dr. Parul and we will be starting the panel discussion on PPH very soon. The poster presentation shall be from 1 p.m. to 2 p.m. and all those who are here for poster presentation shall be there at 1 sharp. It's a short tea break. Please don't go for lunch.
Dr. Parul has gone to collect his luggage from the hotel. So it's just a break of 5 to 10 minutes because he has to catch a flight for Delhi. So he has come, I think. No. Yes. No, that is not. That is Dr. Geeta's number. So be back in 5 minutes because panel discussion on PPH will start next. And after that we'll have a webinar direct relay from Kerala.
Dr. Shazia Monish and Dr. Nishat Anjum, you shall be the moderators in the chairpersons for the next session. So you please wait inside the hall.
Dr. Charu, you have asked me what is the tentative change in timing of your talk. So Dr. Parul is just coming in 5 minutes, I suppose, and then his talk for half an hour, then a panel, that is a panel discussion on PPH, then half hour for Dr. Shaiza's talk, and then the next session will be yours. Dr. Charu is on webinar. She is not present here. So that is why I am talking on a webinar. सर की वो है पेन ड्राइव सर नहीं पेन ड्राइव फिर वो वेबिनार में नहीं होगा। वेबिनार में वो नहीं होगा ट्रांसमिट। कोई बात नहीं,
ये तो कोई बात नहीं,
पर मेरा वेबिनार नहीं होगा ना। पर पेन ड्राइव में नहीं है आपके पास तो फिर कोई फॉर द people who have logged in for webinar, we are sorry to disconnect it for a short period for half an hour. Doctor या पेन ड्राइव से कॉपी करना पड़ेगा। Has someone a pen drive? Okay, so webinar people keep logged in. We'll just be transferring the presentation to a pen drive and then connecting. So what do you need? Yes? ये रख दो फिर हम सर इसमें कनेक्ट करके ट्रांसफर ये पीटी में वीडियो भी चलेगा चलेगा वीडियो ट्रांसमिट नहीं होगा। अच्छा आपके लैपटॉप करना पड़ेगा बेस्ट है कि इसको लगा के 15 मिनट चलिए ठीक है। Sorry webinar loggers, we are logging out and after half an hour please come back.